I'll start a...
Should I start with me?
Yes.
Okay, sorry. I tend to go back to obesity, which is certainly complex, and we just identified it as a disease recently. So let's say I give you money, which I don't have. What would you do to begin to unravel the complex situation of obesity? Because we know it's associated with inflammation. It's associated with 30-plus comorbid diseases. What would you do?
Dr. Attie, do you want to try taking that one first?
Ouch. That's a tough question. I think that you don't tackle it as obesity itself. It has to be deconstructed into its component parts. So of greatest relevance to human obesity is food intake rather than energy expenditure. So we
no. But go ahead. I'm going to respond based on what I know about obesity, if that's okay. Oh, I'm Judy Stern from University of California, Davis. And obesity, type 2 diabetes is my area of research.
Okay, let me qualify what I just said.
Thank you.
I should have said the genetics of obesity is more related to food intake, regulation of food intake, than it is to energy balance.
No.
Can we
food intake.
He'll let you talk, but first, Dr. Attie, why don't you finish your response?
Okay. You don't have to accept what I just said to accept what I will say. I'm using that as an example. Okay, so let's not get into it. We can debate that later. The point I do want to make is that obesity is very complex. You do agree with that? That we can't unravel it as just studying obesity. We have to deconstruct it into its component parts. So if we're going to study food intake, it's mainly a neurological, biological problem. If it's going to be energy expenditure, there's a wide range of endocrine and mitochondrial metabolism and so many sub-problems. And so one has to decide, set priorities and decide what part of that problem are we going to focus on and understand, and be realistic about what we can really study in a well-controlled way. Because the overall, just saying, I'm going to study obesity, put an animal or a person on a scale and weigh them, is not going to solve problems.
Okay, so then I have one question to ask of you all. Agreed, it's a complex problem, and it isn't one problem. Do you think it would be appropriate at a future IOM meeting for us to look at this, dissect it, and apply things that we've learned today and in the past?
Of course.
So can I make, I would say that and I know nothing about obesity.
That's okay.
It's like cardiovascular disease. But it does seem to me I'd be more optimistic about doing randomized trials and actual experiments on humans to test the hypothesis that the microbiome can change your risk of obesity, or can at least treat obesity, because you can measure the outcome within a matter of months or years, not decades. So to me, if you have something that you think is in fact a plausible intervention to reduce someone's weight, then you could do studies and get an outcome within a matter of a few years.
Okay. All right, we'll go to the back. Do you have a question? Yep, you.
Mike Harrison, San Francisco. I love the concept of the endocrine organ, and it occurred to me that it's the only organ that develops after birth. You're not born with it. Consequently, you have a time zero when you're thinking about your studies. And access to meconium of a baby is very easy. And you already have a matching blood sample from cord blood. So that might be a way to structure your studies. And there's a whole field of fetal control of downstream adult diseases like cardiovascular disease. So it just might be a way to think about it.
Okay, thank you for the comment. Do you have a question?
George Hill from Vanderbilt University School of Medicine. Stan, you raised the point during the discussion of the ethics of doing some of these studies. and particularly, for example, when one is doing epidemiological work, what do you see as some of the reservations? For example, if one found in a population that there were a group of microorganisms that indicated cardiovascular disease or chronic kidney disease, and the application of that to their ability to get a job or the stereotyping of a particular population. I thought that was kind of brushed over, or maybe I misunderstood the response. And then, of course, once the individuals have been identified that way, just as in the genome studies, there have been studies that would want to clarify the application of that to further aspects of their life. So I think the ethical applications are something that what we should be discussing as well.
Okay, so to answer that question, I'll give two examples where the ethics of the intervention have come up with our own work. The first was just the concept of if we can show, at least in animal models, that a choline-enriched diet is promoting and fostering cardiovascular disease, and then we start doing studies in humans where we're giving a choline supplement. This is an amount of supplement that's comparable to what you'd have in 2 or 4 hard-boiled eggs a day, and it's getting capsules, right off the grocery shelf. Yet we can show already some phenotypes that are even in whether it's an omnivore or a vegan alike, that we're seeing not only does TMAO level go up, but some of the same biochemical precursors that we had identified in the animal models occurring in the humans. It makes one pause, okay, an obvious question that we've been posing, can we propose a study, for example, take subjects with chronic kidney disease and place them on a choline supplement? You can actually find papers that claim a choline supplement is a healthful thing for someone with CKD. There aren't that many papers out there like that, but then we have data to indicate that that's probably the opposite. And so we have been wrestling with the concept, do we try doing a choline supplementation in CKD subjects where our expected outcome is not a beneficial but a harmful effect, like seeing a cystatin C level go up? That's one thing. A second thing, but more broadly, is if you have perhaps a probiotic in mind that someone has developed or genetically engineered, and let's assume they can get through all of the IND issues that are necessary to do a human intervention study, unlike a drug where you can stop giving the medication and you have a calculable half-life for its disappearance. With a microbe, it's there potentially forever, and so that raises some safety issues and that are very difficult hurdles to get across from an FDA standpoint, and also from an ethics standpoint. Just from a what if something adverse happened based on the intervention, how would you actually undo it? It's almost like the vaccine world. It's hard to undo a vaccine as well. So randomized trials with vaccines have many inherent ethic issues also. Did you want to comment also?
Well, I guess my assumption was that if you were going to do experiments, that the assumption was that whatever you were experimenting on would potentially lower the risk, not increase the risk. So in which case I would argue that you could potentially do things ethically, or certainly that if you have equipoise, you can do it. But obviously, if you're testing a hypothesis, something increases the risk, then that's a whole different story. Going back to the study design issue, it does strike me that one other thing one might think about, I don't know if the country is going to go ahead with the 100,000 child birth cohort child health study that's the United States has been dickering with for now 5 or 10 years. But if such a study does go forward, I think thinking about storing samples for the microbiome and what samples you'd want could potentially, within the context of that already very expensive large study, you could potentially answer some of these questions, nesting them within the child health study.
So I will just point out that the United States is woefully behind Europe when it comes to sample repositories, both in scale, scope. I mean, many countries from the Netherlands to England, throughout Europe, have many large ongoing studies, much larger than what's going on here. Yes?
Betty Sue Masters from the University of Texas Health Science Center in San Antonio. Actually, my question fits right into what you're talking about right now. I want to defend the use of animal models. I think mechanisms can be approached by using animal models. But Stanley, I have a question to ask of you. There are FMO deficient patients. Have you looked at those to see what is going on with them? They have bad odor.
Yes, so FMO3 deficiency leads to trimethylaminuria or fish malodor syndrome. The subjects who are afflicted by this have essentially smell of rotting fish, so it's not a very good disease to have. It's actually not very common, and also the phenotype, there's no known phenotype with respect to a cardiovascular disease. What one would anticipate is they would be protected from cardiovascular disease risk. If you look at, from a power calculation, what it would entail to actually collect enough and look at the ages of subjects who have fish malodor syndrome and their ages compared to the rest of the population to see if they had a protective effect from cardiovascular disease, it's just an impossible study at the present time. So we haven't looked at it from that respect. We do, however, have, as you just mentioned, the animal model in place where we both not only under but also now are over-expressing the flavin monooxygenases for proof of concept in terms of can we impact the disease in one direction or the other by manipulating TMAO levels, if you will, by hitting this node of the meta-organismal pathway.
Thank you.
Yes.
Ron Germain from NIH. I wanted to try to combine the two different comments that were made about the scale of studies, the number of different things you test, the statistics you need to do that, and the question about animal models. And one of the things that needs to always be pointed out is that if you use an animal model and derive a hypothesis, then if you have very large masses of data but you apply the hypothesis to it, you lose the problem of the multiple testing, and things that would be hard to emerge from the data set can be seen more easily. So it's actually the combination of both of them that gives you the best power. And I think that's something that people need to keep in mind, that it's not you only can study it in humans and then it gets enormously large, complicated, and takes forever, and the mouse is a perfect model. It's not. But if you use that to generate the hypothesis, you can actually look for markers in a short period of time in a perturbation study, even with very large numbers of measurements, and actually see a small effect be statistically significant. So you have to balance those off, and I think that's something important for everybody to keep in mind.
Okay, do you have any comment on that?
Yeah, I could just give you an example of that where we can really cut through the multiple testing problem, and that is that in a lot of mouse genetics, we do what are called linkage studies, where the power is really strong. The resolution is not strong, but the power is very strong. It's the exact opposite of what happens in human genetics, where there's high resolution and low power. And the problem in human genetics is that people are testing polymorphisms across the genome, and they're testing too many. But if you get really strong linkage from an animal experiment, you can then do a very targeted search in humans and cut down the multiple testing problem and improve your power by about a factor of 10,000. And we've been doing that with great effect. We've been finding genes in humans that are lurking below the noise, and when you do a focused search, you can find association with human disease.
Tony Gatto,
Yes.
Weill Cornell. Enjoyed your discussion very much. I wanted to ask Stanley a question. In a germ-free animal, does that affect susceptibility to diet-induced atherosclerosis or TMAO levels?
So yes, when you use a germ-free animal or an animal in which you suppressed the intestinal flora, the diet-dependent enhanced atherosclerosis is eliminated, or the choline diet or carnitine diet, both of those have been shown to suppress the diet-induced enhanced atherosclerosis. You also completely block any TMA or TMAO development. So germ-free animals have essentially no detectable TMA or TMAO in the circulation.
Well, we know when GI intervention that's been shown to reduce coronary disease, ileal bypass, which decreases the reabsorption of bile acids. Is there any association in your models with bile acid or cholesterol absorption and TMAO levels?
Yeah, so one of the studies, the one that was published last year, looking at both carnitine as well as TMAO ingestion, at least in the animal model level, showed that there is a very significant effect on bile acid metabolism. Both CYP7A1 and CYP27A1, two rate-limiting steps in bile acid synthesis, are substantially suppressed. The bile acid composition and total pool size were both, well, the composition was altered, the pool size was changed. We think that actually through the LXR, FXR pathway is where TMAO in the liver is having its biggest effect, and via also changes in bile acid synthesis and pool size. And then finally, if one looks at whole body cholesterol transport types of measurements, something like a reverse cholesterol transport in vivo assay that was kind of first developed or reported by Dan Rader and colleagues by taking a peripheral macrophage and radiolabel cholesterol, loading it, and then injecting it peripherally into the subcutaneous tissue, and then following the cholesterol efflux out of the macrophage into the bloodstream, the bile, the liver, eventually out of the body. You can show that in animal models, anything that is raising TMAO levels, so TMAO directly itself in the diet, or choline or carnitine in the diet, if there's intact gut flora, is inhibiting the reverse cholesterol transport pathway. So about a 30% reduction in reverse cholesterol transport was observed. So if the net balance of cholesterol accumulation is due to flux in as well as the rate of flux out, the rate of flux out was being suppressed by about 30% by the TMAO pathway. Okay, are there any other questions?
Fred Marsick, microbiology consultant. I just curious. In those people that have to take antibiotics chronically, and sometimes they're just subtherapeutic doses, I'm thinking of rosacea. Have those populations ever been looked at as to when before they were diagnosed with rosacea and then after, and they're on an antimicrobial diet, as to whether or not they gain weight or they have atherosclerosis?
I don't know the answer to that. Dr. Marty Blazer is still in the audience. You know, I can tell you at the mouse level, where we have taken a mouse and we first started by putting our atherosclerosis studies, rather than a cocktail of antibiotics, we used a single antibiotic, ciprofloxacin, because it was so cheap and it was also effective at suppressing the TMAO level immediately. What we found, though, at the completion of the trial study was that plasma TMAO levels 20 weeks later were identical in the animals that were getting Cipro in the drinking water compared to the control mice. And so even though we knocked down the microbes that were susceptible to the ciprofloxacin, then the remaining microbes that were resistant took over. And so subjects who are chronically on antibiotics, whether it be for rosacea or acne or whatever, they are now colonized with resistant microbes. Now, the impact from a healthcare standpoint on obesity, cardiovascular risk, I don't know that anyone has actually ever looked at that. I'm not familiar with that. Yes?
Dan Drachman, Johns Hopkins. Can any of you comment on some of the attempts to switch the human microbiome therapeutically?
Okay. So in terms of switching the human microbiome therapeutically, there's been different approaches that have been used. The blunt force one is a fecal transplant, and I mentioned earlier the studies that were done by both for subjects who have chronic C. difficile. In a large proportion of those individuals, just one round of therapy had immediate effect. And in the majority of those who didn't respond to the first cycle of therapy, they did at the second cycle. So much in the same way we heard about how thinking of the population of the community of the microbes in a three-dimensional topology as a local minimum well. By doing the fecal transplant, we kind of got them over the one hump and into a new, stable, alternative community composition. I'm not sure, I mean, beyond fecal transplant, there's prebiotics is another intervention, you know, such as fiber, and then chronic dietary intervention. It is, when you look at the microbial composition in omnivores versus vegetarian or vegans, subjects who have long-term dietary patterns like a vegetarian or vegan have a different microbial composition and function. And with respect to this pathway I was talking about, vegetarian and vegans, when you give them carnitine, which is a food source that's almost exclusively found in red meat, initially they make very little, if any, TMAO from the carnitine. They can still make it from choline because they get that in their diet, but the microbes that are used to seeing or that enjoy carnitine as a food have not had it, and so their numbers are suppressed, and it's only after chronic carnitine exposure do you see those levels come up. So diet as a manipulation of microbial composition is also a very strong factor.
But other than C. difficile, are there other attempts to alter the microbiome therapeutically for obesity, cardiovascular disease, etc.?
So there are ongoing studies now looking at manipulation of microbial composition as in a treatment of metabolic syndrome or insulin resistance. There have been studies with fecal transplants or duodenal infusions in those subjects. There also have been experiments where the fecal material is cleaned and put in, packaged in capsules, and literally 20 some odd capsules are taken per day. Is ongoing clinical trials in that regard. Most of this is actually not happening in the United States, it's happening in Europe because the regulatory barriers to doing kind of fecal transplants are, right now the FDA is kind of just turning a blind eye to it. Okay, I'd like to finish by thanking the panel for your discussion. Thank you very much.
And I, too, want to thank all of you for a wonderful discussion and very thoughtful comments. Just in comment to a recent question, there are some studies now looking at the effects of long-term antibiotic use in teenagers, for example, who have acne and are treated with tetracycline. And although I don't think the results are fully revealed, there aren't, to my knowledge, any dramatic effects on weight gain, for example. But if you think about Marty's arguments about windows of vulnerability early in life and other work, you might argue that that treatment later in life with antibiotics may not have the same kind of effect that early use might. I have just a